I want to start now. I welcome everyone. I wish I could personally acknowledge you and bow or thank you personally for coming. This is TechSoup Connect. It's July 21st, 2022. Timebanking Organizations Chapter. My name is Jerome Scriptunis. I'm the founder and head of ytbglobal.org. Our speaker today is Ken McGill. I'm going to introduce him a little bit more brief in a moment. He is a solution-focused care scientist with Opeeka.com, and he's going to talk with us about person-centered intelligence solution. What I want to tell you, what I want to say as we go into our session is that a question that has been coming up in the work that I do and in my personal experiences recently is, how do I know what I don't know? And we laugh and chuckle about that. It's what a rhetorical question. There's no way to answer it, but it seems to me that the people at Opeeka had that in mind when they were developing P-CIS. And as I learn more and more through the coaching and instruction from Ken and others at Opeeka, there are three phrases that I found helpful, or three terms to help me anchor what P-CIS is and does, or at least a portion of what it is and does. And those three phrases are success-focused artificial intelligence, number two, care circles, and number three, story map. So Ken is going to unpack that for us. What I wish to do next, though, is ask you to listen to this short video introduction before we welcome Ken to talk with us.
At Opeeka, we promote well-being for all. Opeeka has created a person-centered intelligence solution called P-CIS that supports person-centered and success-focused care. Person-centered care is defined by the World Health Organization as the act of empowering people to take charge of their own health, rather than being passive recipients of services. Patient views, input, and experiences can help improve overall health outcomes. Success-focused care is the practice of defining what success looks like in collaboration with a patient, while helping that patient track progress toward those goals. P-CIS supports low-burden, automated collection of information from patients. Through HIPAA-compliant text, email, kiosk, or tablet, patients can complete information about the reason for their visit, their symptoms, progress, and their goals in care. P-CIS is questionnaire agnostic, and new questions can be calibrated as needed to gather information on social determinants of health or other circumstances and factors. Questionnaire results are automatically integrated with electronic medical and health records, so that clinicians see the information immediately. If it is a reassessment, then clinicians can see the change in responses over time. This clinician lets the patient know that she will be receiving a follow-up questionnaire to ask her about how she is feeling after she begins her treatment. The clinician also lets the patient know that her responses will help identify the right treatment for her. P-CIS automatically schedules the appropriate follow-up questionnaire for the next week. Behind the scenes, P-CIS integrates patient-gathered information with medical record data, such as history of diagnoses, medications, lab results, and other clinically relevant data points. It looks for patterns of success for people, among those with similar circumstances. Using customizable success-focused AI models, P-CIS identifies advice, recommendations, treatments, practices, and personal goals that have resulted in positive outcomes for similar patients. Building a knowledge base, it harnesses the power of sharing clinical intuition within an organization, forming a unique brain trust that contains their own evidence-based recommendations for success. By joining together personal circumstances with historic health information, it learns what works for whom. The next time the patient returns to the doctor for more care, the electronic record displays suggestions for clinicians to consider, based on patterns of success. P-CIS supports success-focused care. At the population level, P-CIS allows organizations to monitor health outcomes in real time. They can see subpopulations who are thriving, as well as those who would benefit from additional insights and recommendations. More successful care results in faster recovery and healthier service populations with lower costs for care. Visit Opeeka.com to learn more.
You're muted, Jerome.
Thank you, Ken. The materials that we're going through today, I put a link into the chat, and I'm going to invite our speaker, Ken McGill, to unpack these ways of learning and thinking about and understanding what person-centered intelligence solution is and does, and why it's extraordinary. It's a breakthrough healthcare technology. I'm honored and just happy that gave time to educate me and allow Kenneth McGill to be our speaker today. Kenneth, welcome to TechSoup Global.
Thank you, Jerome. Thank you, Eli. And thank you for all the folks who are attending and will be tuning in. It's an honor. And I know the work that's being done by TechSoup and those who are on the call. I'm sure you're doing a lot of heavy lifting. So we are at Opeeka just glad to have this opportunity to support collaboration. And Jerome said, we want to capture three main pillars, if you will, with regards to what our work is all about and what we've tried to accomplish. Acknowledging first, though, the co-founders, Dr. Kate Cordell and Ken Connect, having an idea to meet a need and to find a solution. And it's really important to understand that even before the worldwide pandemic, how technology and the use of data was really so essential when we think about whole person care, person-centered care. And Jerome, you actually brought up two main areas for me when we think about social determinants of health and well-being, or if we do want to talk about health equity, we need to lead with the data. And TechSoup and the work that you've done with the Timebanking and Dr. Christine Gray, who's on the call as well, and a few other people that I can highlight as well, they're doing work in making sure that the data is leading the process. So what I'll do is I'll unpack, like Jerome said, and please feel free to use the chat and ask questions. And we really want this to be a beginning of a conversation. We want to ask you to think about what you would need in terms of what we talk about here and reach out to. Love collaborating, love to find solutions. And if we work collaboratively together, any challenge that's ahead of us, we could certainly transform and make our world a better place. So the first, Jerome mentioned success-focused artificial intelligence. And I'm sure everyone who's on this call understands AI and machine learning. But here at Opeeka, we have a revolutionary special type of artificial intelligence, which we've actually labeled success-focused. So instead of going and regressing to the mean in terms of predicting risk and mitigating risk, we want to go beyond that. We understand that keeping everyone safe and healthy is a starting point, but it's not the end point. We want to look at and make sure that we utilize the data that we have as clinicians or experts in our area of human services and supplement histories of success that we learn from others that are served and make the most appropriate decisions for care. So the takeaway is that artificial intelligence is very useful, machine learning, but rather than just regress to the means, we want to regress to success. We want to raise that bar to the highest level so that we can prevent institutional biases that might be within our data and just return successful outcomes that are based upon past success and make those decisions accordingly. And I will add here, Jerome, if I'm allowed to expand upon the success-focused artificial intelligence, it is very helpful in doing the work. And we have all been impacted by the work shortages, even before the worldwide pandemic. And having people remain in the job and be successful in the work itself is very important. And here at Opeeka, we want to acknowledge that. And part of the success-focused artificial intelligence and the AI and the analytics that you can delve into, which was part of that video, staff, including those staff who might not be technology savvy, I'll actually admit here, full disclosure, I am a licensed marriage and family therapist, clinical fellow for almost 2 decades, or over 2 decades now, and worked in a statewide children's system of care for almost 20 years. And data or technology was something that I really appreciated, but really didn't know that much about. So leaving and moving over from Rutgers University, the Behavioral Research Training Institute, over to Opeeka, and listening to Dr. Kate Cordell and Ken Connect, what they've created. And when they explained it to me, how easily I was able to understand and utilize this amazing platform. So those who are on the call, and there might not be many, there might be one or two that might not be able to understand the deeper dives to data. It is a very user-friendly platform that allows for information to be shared. And when you think about information to be shared or data to use, think about that on the team level, direct care, the supervisory level. And then if you take it a step further to the agency or the larger systems level, that's what Opeeka, that's what we and Dr. Kate Cordell Can Connect wanted to accomplish. We didn't want to add another layer to technology. We wanted to add dimension and be able to bring the technologies together. So when we think about success-focused artificial intelligence, think about gathering and bringing into a system in real time allow for unbelievable predictive analytics to occur.
Ken, let me just do a check-in point on this with the success-focused artificial intelligence. Is it correct for me to understand that by using P-CIS over time, P-CIS learns about the work that has been going on, and as time goes by and more history is collected, it refines how it presents insights to the care team. So it gets better and better over time to help staff get better and better at what they're doing.
Beautifully said, Jerome. And when you started off about what we don't know is what we don't know. And what this absolutely does is supplement what we don't know. And it does it in real time. And so that we can learn from the data and we can utilize our clinical intuition, but supporting really solid, success-focused outcomes. It does exactly what you just said. It learns and it does it all in real time.
So let me ask you then to talk to us about the next point about care circles and how P-CIS involves everyone, and I think also speaks to the reducing the what is it that I don't know to a smaller and smaller thing so that it's not affecting the work as much. And so I'm going to move over to the next slide, and I think I have a version of it here. I'll just boost it up a little bit. So if you would talk to us about care circles and secure sharing of information across the care team.
Absolutely. Many of us know that when we go and we're involved with a specific system, we're often seen within our single story. And as human beings, we are multifaceted. We're not a single story. So again, what was created here at Opeeka and Person-Centered Intelligence Solutions, or P-CIS, was to bring all the pieces together. And we want to do that in a way that's completely secure, HIPAA compliant, but there really are electronic health records who have so much, a wealth of information. And we want to share that and create care circles so that treatment teams or a team can have a multiple focus on this one individual that we're serving or a family. And we're going beyond the single story. So when you think about P-CIS, it can connect with electronic health records. So if we look at our focus, which was on children in the system of care, and I know we might have folks from Florida who are on the call, California, who's doing a statewide children's system of care rollout. We have other folks across the globe who are also thinking of systems of care. And so we have this opportunity to share with the same person and only information that's helpful for treatment purposes and utilize it in real time. So electronic health records, think of this as a collaboration of electronic health records in support of a care circle or a team, so that we can actually, rather than just treat symptoms, we can look at increasing success and outcomes based upon what that particular individual or that family wants to accomplish, because they're not a single story. And you can actually use pieces to ensure or increase success-focused whole person care. So when we think of care circles, Jerome, first thing that came to my mind, I don't know if it's doing the same for those who are listening now, but the child family teams or treatment teams. It is so important, though, to have the information that's useful so that everyone is on the same page. And it also does something amazing, these care circles, and allowing the shared information. It prevents someone from having to repeat their story over and over again. Think about that. If someone who's attached to a different system, and maybe it's a new worker that's being assigned or a new system that arrives, having to tell the story over and over again, especially if it involves trauma, which most of the times when we think about the people that we serve, the individuals, everyone in dealing with the impact of COVID in particular, has experienced something. But if you have to repeat your story over and over again, a couple of things happen. One, you feel like no one is really on the same page or have to start over from the beginning. And secondly, it can re-traumatize that person in a way because they have to tell someone everything they need to know. And that's not fair. That's something that we at Opeeka want to eliminate. So
Hey,
the
Ken,
takeaway, yes,
excuse me, please. I want to take an opportunity to state a comment that came in.
please.
Does everyone have to be connected with this program to share? In other words, I think what that is also asking, is the person in care associated with one primary organization? And how is it logistically possible for others to have connection to pieces of the story?
Great question. Again, when someone, the lead, for example, whoever, we're working with California in the rollout of our statewide system of care. So child welfare is the lead. And I saw Maria's message in there in the chat. So if they're the lead, the child welfare worker, the administrator at the administrative level can create care circles, bring people in. They don't have to sign up or have an account with Opeeka or P-CIS. They can collaborate with an invite. And that invitation can be set up so that only information that's needed or useful will be shared. I'll give a concrete example. If child welfare is the lead and they want the school, which is part of the rollout of the statewide system of care in California, a system is a system partner. They wouldn't necessarily want everything about that child's trauma or the family's trauma to be put out there. So they would only have access to the information securely in a way that would be helpful for the child's needs educationally. It wouldn't say under like the trauma item, if you're using the child adolescent cans, confidential. It would actually just be removed from the information that is shared. So it allows for team discussion and care circles to all be on the same page with information that's useful to them.
So Ken, who decides what's shared? Who has the say in that?
Great question. They're set up in a way that pieces on the direct care providers level have only access to those individuals they serve. Okay, so that would see the number of children, youth, individuals. Any human services field is what our person-centered intelligence solutions or pieces can help. Human resources, school systems, hospitals, the list goes on and on. So if you look from the direct care provider, a person providing direct care, up to the super administrator. So the super administrator is the one who makes the decision, or the ones who make the decision in terms of what types of care circles, who gets involved. They have a certain end date for that particular individual or family. So there's such customizability in terms of the way the system can support all the work, all the human services.
Ken, another question came in, and maybe you see it on the chat.
I haven't been keeping up. Sorry.
Okay, so let me, that's why I'm reading them to you.
Thank you.
So the point is, and how is this related to the information blocking, which rolls out in October? Is it all shared? So can you shed some light and give context to that question? I'm not sure, or
That may be more specific to the rollout, and I don't want to misspeak in any way. So please, in terms of other specific questions for the rollout, as I mentioned, throughout the beautiful state of California. But in terms of it being set, it obviously will be set forth by the administrators who are saying this is what the system of care is determined to do, the structure of a child family team. And if this question is related to California, I have to say I'm incredibly, being a systems of care person myself, for the 2 decades that I've served, they have an integrated core practice model, which is incredible, an interleadership council so that each county has the ability to come together and to make decisions at the local level. So it is absolutely something that is so customizable and also structured in a way that could support all the work. And I see California, so that it's not one size fits all.
And
That
excuse me
answers the
again,
question.
I want to keep pace with some other comments, and then we're going to move on to the next section, and we'll allow time to summarize and recap. So some of the other points that I'm going to read off to you, and maybe you can make a general comment.
Sure.
One is, how would this work for people over 18 who would not consent? That's one of the comments. And then another comment is, how will this program be made known to DCS, et cetera, in Arizona? And then if you have an opportunity to scan at the chat, you'll see some points that Chris Gray is making. So can you comment about person in care not consenting?
Sure. And I know in the statewide system of care we work, Jerome, that 14, in terms of it being a voluntary program, is the age of consent in terms of ensuring that wanting to participate and share this information. It would always be set forth so that the person who is the either brought in for a care circle or the person being served needs to consent. This is their care. And how that's all set up would be determined based upon each individual state. So I'd love to talk further about different consents or some of the possible barriers that people might be thinking of, and see how we've gone through with our customers currently, and which have been even outside of the continental United States, in dealing with some protected information and set forth guidelines. So hopefully that gives an answer somewhat, but it's a start of a conversation.
Yes. Let's move on into the third aspect that we wanted to cover today about story maps, assessments, flexible questionnaires, and IDEA.
Yes.
The next few slides they have a lot of information on them. I know we're not going to be able to speak to maybe every point on them, but they're like a reference. And so I'm going to put one of them on here. And Ken, I'm going to show you them. If you wish for me to use one over the other,
Sure.
let me know.
Why don't we start there? This is a great visual to show in terms of where the information and the data leading the information to support success-focused artificial intelligence. This gives a great snapshot in terms of matching those who are in care with specific programs, interventions that'll be really useful based upon their needs that have been set forth. The ways the information can be sent out and the use of technology, email, text, is shown there. And that information is brought into P-CIS in real time. So whenever information is updated, it's updated in the system. And you look at the personal data, the person's data, and then population outcomes. You could see, and anyone who uses this at the more administrative level can pull out what's happening for the individual child and youth, but also compared to the population or populations that are being served. And as a former clinical director for a care management organization, this would have been incredibly helpful for supervising the care manager supervisors, the licensed clinicians who are supervising the care managers, to show at a glance at the individual child and families level. So those individuals who might have been re-involved with a system such as juvenile justice, maybe sitting in a detention center for too long of a time, as well as looking at a glance of all the youth or children that was under the supervision of that one particular supervisor. I could see clearly at a glance. So the story maps, which will be, I think, the next one that you showed.
Let's see. Let's see. Is it this one?
That's perfect.
Ken, if you could also add in some insight regarding how the person in care themselves benefits
Great
from
question.
P-CIS. Okay, thank you.
Great. And again, I'd love to poll quickly the group and how many people use the TCOM tools or the CANS tools, the Child Adolescent Needs and Strengths. It would be great to see. And this is an open domain tool. And if you're not familiar with the CANS or the TCOM tools, please let us know. We'd love to share information. There's no cost to use them. And it's based upon computed metric theory. So I see Maria definitely uses the CANS. So what you see here is a perfect example, or can be applied to any and all assessments that come in. but we can actually look with using the cans at an immediate glance of that person's story, not a single story. So this is going to bring information in more than just the cans. If child welfare has their safety assessments that are done, any type of psychiatric or psychological assessments, schools, information, or natural and formal supports are all coming here. But at a glance, if you look at the center where your eyes are taking you, the targetable action outcomes, these are the areas for the care plans. And you could see in priority what needs are the ones that we're working on to keep a person safe and move them forward to success. If you look towards the right of the targeted needs, you can see useful and built strengths, things that we're going to be putting in the plan. But if someone has a functional strength that they can utilize in care, great, let's work on that. And these can be altered in any way. So if a priority changes, this can actually be done in real time to when we print this out into an actual care plan, it will make sense. So that person who's in care can also see what's being worked on. And then when you look at the two other sides quickly, the underlying needs are things that we can't change, but we need to know about. So traumas that occurred, and then background needs are, think of those as the parking lot. And the other two below that, your question, Jerome, about the person's involvement. These are circumstances and preference. We need to know if that individual has a preference need based upon their culture or their ethnic backgrounds. So if someone has that preference, we want to abide by that. We want to respect that. And then the other towards the right are the opinions. Is this person being heard in care? We can ask questions like that. I think that's one of the most incredible snapshots of the work anyone can look at, in particular, everyone who's being served. And goals are listed there. This is just a really a nice, easy way to look at it. You can see a super story, which is everyone who's attached. You can just, again, see all the different things being brought in. So it's not a single story map. It is absolutely all the stories. And before I forget,
I was just wanted to ask if you could also comment as you're sharing this information
Sure.
on when we think about person in care, of course, that might bring to mind an individual who is enrolled with perhaps a behavioral health care organization. Now, as you were talking to us about the care circles, could include a child welfare, youth justice, the school system. And so for an individual's, whether it's youth, and I'm thinking about the work that I do with youth time banking, and we're certainly focused on building strengths as a way of keeping youth active and productive in community. Do you see that P-CIS can be used as a person in care is actually not in care anymore, but back in with the school system, but maybe still connected to child welfare or working through a youth justice or probation program? Is that still possible?
yes, you're saying if that person is still open to care and some of the team members are no longer actively involved, as long as
Right.
the primary care being, in your example with child welfare, absolutely, you can continue to move forward. Now, I was thinking while you were asking that question about those children and youth who were in foster care, out of home
Yeah.
placement. So
Yes.
absolutely. And you think about some of the customers that Opeeka has and some of the accolades they've given us, which are so incredibly valuable. And so we look at, for example, our FaithBridge foster care program. Jesse Esterling mentions about the integrated workflow that we have established using P-CIS has allowed our organization to be more effective while creating more meaningful use of electronic data to help us better serve, visualize, and document our work with foster care, children, youth, and families. So
And bringing up some of the testimonials, if I can, I want to see if they'll advance through, or at least I'm going to put this link in the chat. I think it's starting to scroll through like the gallery. And so we have about 10 more minutes left.
Can I-
Please? Yes, go
I was
ahead.
going to say, I want to make sure I don't leave this out, because when I first learned about and joined Opeeka and sat down with Dr. Kate Cordell and Ken Connect, when we mentioned that our system is truly agnostic to assessment agnostic, And that was the goal. I found out something incredible in terms of the depth of what this can do for not just children and child welfare. We work again with an amazing group in Illinois in terms of the Lutheran. Make sure I get this, Lutheran Social Services of Illinois, and their group in terms of providing in-home care to the more seasoned population that we serve. But when Kate first mentioned about this system being agnostic, you can bring any system in. She used the term that she had an idea of how she can keep it agnostic to assessments, but also make it useful at the day-to-day data collection. And she talked about her idea. An idea is an acronym for Inquisitive Data Exchange Analytics. So again, someone who's not necessarily that data person, that data scientist who takes it to the really deep levels, the question or the takeaway as a clinician that I share with everyone and every call that I'm having or conversations is that idea or inquisitive data exchange analytics is about any person that we ask a question of and we get an answer. So think about person, question, answer. That's how it can be calibrated into pieces. So when you think about supporting timely care delivery, using evidence-based practices, meeting certain guidelines to make sure that the deliverables for the first time they're seen, follow-up care, connecting the services, this needs to be done when, gentle reminders to the workforce in terms of when certain reports are due or a certain ping points, touch points need to happen. So think of the idea or inquisitive data exchange that you can make if you're working with someone, if you're in the human services field or the employee assistance program in corporate worlds or large organizations. Any person that you want to have a question about, an answer that you're going to collect can be calibrated. So you can actually create your own assessments, unique and developed for your organization. So that I thought was one of the most amazing way to prevent single stories from developing, but also expanding the story and the story map, and then taking it to the level of success-focused artificial intelligence. So I just thought that was one of those moments where you go, wow. It removes the institutional biases in terms of even what types of assessments that we might be using and bringing other assessments and other informations, questions that we have about that person. That was a mind blower. That was what I recall Dr. Lyons on a few other calls that we've had. It's a game changer.
A question came in about the story map again. So what I want to do is go back to the Opeeka site, and there is a page on there. I'm going to put, let's see if that comes up, that gives supporting explanation to the discussion that Ken is sharing with us. So is this what is referred to as the story map then,
Correct.
Ken?
Correct.
Okay.
So at a glance, the larger story map, you could see what you're working on, what the team's working on in the center, and then the other components, because we can't work on everything. And that's where we think of TCOM or transformational collaborative outcomes management. We want to place things in a way so that we don't feel overwhelmed. We're not focusing on things in a haphazard way. We're focusing in on things and items that are very needs and strengths that we're building in a very meaningful way to that person in care, but also including important things that, such as their opinions, being culturally responsive to theirs, and background needs to think of are the ones that we're put in the parking lot that we really are working on, maybe in a very ancillary way. But this brings, for me, a data to life and a three-dimensional multi-story approach. And Jerome, if I can quickly, those individuals who said they use the TCOM tools in CANS, here's another game changer. When you score a CANS 0, 1, 2, 3, those numbers are really meaningless to those people that we serve, those individuals. But wouldn't it be great if we put a 2 or a 3, and those who aren't familiar, a 0 means that there's no need that we're going to work on, so nothing we're going to keep focused on. 1 is a watch and keep an eye on, or history. 2s and 3s are actionable ratings for the CANS tools. So a 2 would indicate if there is an area of need, such as depression. So that comes to life. So when you put a 2 down and use pieces, you could see that's a need. And actually we can create the progress notes utilizing a tool like the CANS. So input the information once and the output of information goes in multiple dimensions. And that's why it's not another layer of technology. It brings to life. So basically what I'm saying is if you complete a CANS, you'll have a complete narrative that you can use with your case notes. It's been set up that way. So if you get excited about this and you want to further dive in, please reach out. We'd love to give you a demo. And if you, again, want to get a demonstration from someone who literally wrote the book, Dr. Kate Cordell, when you hear her speak and the way this was created, you're just in awe. And I always love to say when people write the book on this, bring them in.
So I'm putting up I'm sharing the webpage from Opeeka's site. So we have a few more minutes, Ken. I'm going to read one of the comments came in. One is, thank you, Ken, for the narrative. Do patients have a mobile app? And another comment that came in is, what kind of release has to be signed to use this system? There's a concern for the possibilities of lawsuits. Could you please comment on mobile app potential and signing of releases to use the system?
Absolutely. I'll start with the lawsuit, the more urgent of the, and then work my way backwards on that, is that when you think of system of care work, there are ways in setting up to make sure that the person in care always has the right to not disclose information or have that information shared. So we've set forth, and it's been set up in a way that has met so far every single state or system that we've worked with. So it is completely ensuring that information that's going to be shared. That person has the knowledge and right to understand that information will be shared or not shared based upon their preference. And then the other, let's see if I remember the first part of this was
about the mobile app.
Yes, the mobile app. The assessments that are used or the question about the person and answer gets sent in an app form to the phones, tablets, or any type of portal that's being used. So that's fully HIPAA compliant because there's a second sign-on or a sign-on. You'd get emailed a code only emailed, and that there's a set identifier to make sure that the person this information is being sent with is going to be securely given. And the use of the word app, I love that because TechSoup has public good apps, offered a house of them, and incorporating information that's being gained through the use of these apps. The one app in particular supporting Safe Shelter Collaborative, which is happening in states such as Florida, Texas, and elsewhere across the country, is to the impact and to serve those who have been part of human trafficking. And so an app like that, or any of the good apps, that public good apps that TechSoup has, that information can be brought right into P-CIS. And if a person or group has an electronic health record, that's where the public good apps can come right in and be brought into the large data selection or data part of it.
Thank you, Ken. I want to squeeze one more in. We've got about 55 seconds, maybe. A question about, there's an interest in another webinar from Opeeka about the person in care perspective and more explanation and discussion about how the person in care participates or benefits from. Does the person in care themselves have access to P-CIS?
The person in care, just like anyone in care, could have access to the information. But in terms of them logging on and to see, there's certainly a family or an individual portal that they have access to their information. I would encourage you, if you go on to Opeeka, our website, www.opeeka.com.
Yes.
All the webinars that we have, and we have a webinar to support the Family First Act. And you could see very clearly in terms of some of the specific deliverables or milestones that we wanted to capture using P-CIS. And I think that might answer a lot of the questions around a person's view of what's being gathered, but also their willingness to share and to have that control. Those are wonderful webinars.
I'm scrolling through that page
right
as we wrap up the session.
Yep.
Is it
a little further down? Value-based care, the FFPSA right there, the family.
Keep going.
I think there was one that we actually had right there.
Oh, this one right here. This one.
And so there's several, because again, when we look at the Family First Act or the FFPSA, there was so much to cover that we did have several webinars, and we do have several webinars that we offer to take it from every single person's perspective, those foster youth and families, and right to the child welfare, the departments who are responsible to meet those needs. And I see a wonderful thank you. Thank you all for this opportunity. And again, to Eli, to Jerome, to Christine. I saw Stephen from Uganda, and I saw a few other folks from across Robert.
We had a representation, I think, from the Caribbean, from Africa, from the US, a little bit from Europe, I think. Last point, Ken, on the webinars where it says register, are these webinars that have already happened?
Yes,
Or are they?
these
Okay.
are actually, so in terms of registering, being able to ask questions that will come to us in terms of answering. So we're really trying to take what we do in terms of real-time data analytics, and we want to model that. So please.
So I just clicked on one of the to show as an example, and if someone clicks in that and fills out the form, they'll actually join this webinar or
That's
have
correct.
it presented to them.
That's correct. And I also want to let people know that we have an upcoming webinar that's going to happen in August. And I really encourage, especially with what's going on in the schools, and having a school administrator, a nurse, really amazing, keeping everyone happy, healthy, and a pediatrician. And so we will send that out to everyone who wants to participate and be a part of our mailing list. We don't send a lot of things other than our webinars, our podcasts, but this is our part of our mission is to support collaborative efforts, and innovations in care collaboration is the podcast series that is offered. And the webinars, we've tried to highlight innovative ways that we could do the work. And I had the opportunity to do a webinar with Jerome on youth time banking. I've had an amazing podcast, but I've also had with Dr. Randy Scuniers, Dr. S, who is doing some creative work around supporting children and youth, or youth that are involved with juvenile justice or systems, and utilizing the hip hop culture. And so tune in, and if there's some great ideas, let us know.
Thank you, Ken. Thank you, TechSoup Global. Thank you, everyone across the world who joined us today. If you wish to have more information about Opeeka or P-CIS.com, the links are in the share area. And I'm going to put the last link in here, and wish you all a good day, good afternoon, good evening, and thank you for your time and attention. Thank you, Opeeka.
Thank you, everyone.